Hello friends, today we are going to discuss regarding ECG and echocardiography findings in a patient with hypertension. As we have already discussed, hypertension produces left ventricular pressure overload and which causes electrical, structural and mechanical remodeling of the heart. So ECG basically detects electrical changes, whereas echocardiography detects structural and mechanical changes. Now, we will go through the pathophysiology of hypertension briefly. There is a persistent increase in systemic vascular resistance which causes left ventricular pressure overload, which further leads to myocyte hypertrophy and left ventricular hypertrophy. This will eventually lead to diastolic dysfunction and diastolic heart failure and eventually systolic heart failure. So ECG and echocardiography basically reflect these changes. Now coming to ECG changes first. ECG reflects electrical changes. Since there is increase in LV mass, it will lead to increase in QRS voltage. So there is tall R wave in V5 and V6, there is deep S wave in V6 and there is increase in QRS voltage. So there is a criteria which is called as Sokolow-Lyon criteria. So if tall R wave in V5 or V6 plus deep S wave in V1, if it is more than 35 mm, then it is considered significant. It is representative of left ventricular hypertrophy. So we'll find changes of left ventricular hypertrophy in ECG. Number 2, left axis deviation. So left ventricular dominance shifts QRS axis leftward. Number 3, left atrial enlargement. So due to persistent hypertension, there is increase in LV filling pressure which causes left atrial enlargement. So there is notched P wave in lead 2 and biphasic P wave with a deep terminal negative component in P1. Then atrial fibrillation. Atrial fibrillation may result due to left atrial dilatation and ventricular ectopics due to hypertensive heart disease. Then strain pattern. As we have already discussed that in a patient with hypertension there is increase in LV pressure overload, due to which there is hypertrophy of the myocardium which can lead to subendocardial ischemia. So there is ST segment depression and T wave inversion in V5, V6, 1 and AVL. This is called as strain pattern and this is representative of advanced systemic hypertension. Now we will discuss echocardiography findings in a patient with hypertension. Number 1, concentric hypertrophy. Concentric hypertrophy is the most common finding that we will come across in a patient with hypertension. Number 2, diastolic dysfunction. As there is thickening of left ventricle, it becomes stiff, there is impaired relaxation, so there is decrease in EA ratio. Number 3, there is increase in left atrium left atrial enlargement, which is basically a reflection of increased LV filling pressure. Then pulmonary arterial hypertension. So if the hypertension is persistent for a long period of time and it is not treated adequately, then it will lead to increase in LV filling pressure, which will ultimately cause increase in LA pressure, which will further lead to rise in pulmonary systemic venous congestion, and this will lead to increase in pulmonary arterial pressure. So we have to look at TR jet velocity. So normal TR jet velocity is less than 2.8 m per second. If it is between 2.8 to 3.4 m second, we call it mild pulmonary arterial hypertension. If it is between 3.5 to 4.0 m per second, we call it moderate pulmonary arterial hypertension. And when it is more than 4 m per second, we call it severe pulmonary arterial hypertension. And then we have to calculate pulmonary artery systolic pressure. So if pulmonary artery systolic pressure is less than 35 mmHg, it is normal. And if it is between 35 to 50 mmHg, we call it mild pulmonary arterial hypertension. If pulmonary artery systolic pressure is between 50 to 70 mmHg, we call it moderate pulmonary arterial hypertension. And if it is more than 70 mmHg, we call it severe pulmonary arterial hypertension. And finally, RV, and there can be left ventricular systolic failure. So in a patient who has persistent systemic hypertension and hypertension is left untreated, so initially it will cause hypertrophy and eventually it will lead to dilatation of LV and left ventricular failure. So on echocardiography, we may find LV failure or LV systolic dysfunction, which is manifested as reduced ejection fraction, and then valvular abnormalities. So we may come across mitral regurgitation. It is functional due to LV dilatation and displacement of papillary muscles. Thank you.